Welcome everyone again to the University of New Mexico Law and Mental Health Didactic Series. This is weekly discussions of practice and science by experts in behavioral health and the law, hosted by the University of New Mexico Department of Psychiatry and Behavioral Sciences and the New Mexico Behavioral Health Services Division. I'm Anthony Perillo, the Forensic Psychology Training Director here at the University of New Mexico in our Division of Forensic Behavioral Sciences. For our talk today, if you have any questions for our presenter, make sure you enter them in the Q&A box anytime you feel comfortable. We do hold questions until the end. We try to get to as many as possible, but it's not always possible to get to all of them. Oftentimes, it's not possible to get to all of them. If you are pursuing continuing medical education credits, there will be a sign-in sheet in the chat box posted shortly. And if you're pursuing APA continuing education credits, there will also be a link for a survey to process and complete for your CE credits. That will be posted in the chat box in the latter portions of the talk. Make sure you keep an eye on the chat box near the end then. Make sure you open the link. If it doesn't work for you, copy and paste it for later. And make sure you save your certificate after you complete the survey because we don't have access to the certificates of completion after the fact. As a heads up, recording link and PowerPoint slides for this talk should be available to you sometime later this week. And for next week's talk in the series, we have Dr. Pamela Yates. We'll be discussing self-regulation models for understanding and treating sexual offending behavior. But circling back to this week, I'm excited to introduce you to today's speaker who will be discussing structured guides for other directed violence risk management training and practice. This is Dr. Chris King. Dr. Chris King is an associate professor and the director of clinical training for the clinical psychology Ph.D. program at Montclair State University. He teaches and conducts research related to adult and juvenile clinic forensic psychology and mental health law, correctional psychology, and police and public safety psychology. Dr. King developed and supervises a university-based training clinic in DBT for persons referred by federal reentry courts. He also currently provides treatment services and public safety pre-employment screenings in private practice. He's a licensed psychologist in New Jersey, a licensed psychologist in New York State, and a licensed attorney in Pennsylvania. I'll add, he's also been working on a number of innovative works to improve services to legally involved individuals, including video game technology to integrate criminogenic risk assessment and treatment, as well as broader risk assessment management work that he's going to be sharing with us today. So Dr. King, Chris, on behalf of the University of New Mexico and myself personally, thank you so much for joining this series. I'm excited to have you sharing your expertise, and it's an honor to have you join us. I will go ahead and throw it over to you.
Thanks, Anthony. And thanks everyone for being here today. So just some disclosures up front. The short of it, when you fill out your CE evaluation, after this, no financial conflicts of interest to disclose for this talk. So I'll just leave this up for a moment so you can see those disclosures. And then in terms of an upfront disclaimer, that this is sort of my talk, my work, and so it doesn't necessarily reflect the views of UNM, of course. And so let's get into it. Again, the topic for today are two new structured guides for other directed violence risk management training and practice that I developed. And in terms of learning objectives, the first learning objective is for all to know how to access two new and free other directed violence risk management guides, which are meant to serve as a complement to pre-existing violence risk assessment tools and approaches, and to feel that they understand them well enough to be able to critique them on a preliminary basis given their current developmental status. The second learning objective is for all to feel sufficiently oriented to the guides to be able to explore them further in the context of training and with appreciation of their current limitations, potentially in practice. And the third learning objective is for all to be able to describe a research program that would be needed for the structured approach to violence risk management represented by the guides to move beyond being evidence-informed and potentially into the realm of being evidence-based. So I want to start with the prompts for this project. The first overarching prompt was just my sense that the field to date has generally been more explicit about other directed violence risk assessment and to some extent case conceptualization than it has been with respect to management per se. In other words, implementing recommendations that might be generated based on an assessment and a case conceptualization. So for example, consider the utility of structured professional judgments about violence risk when possible, right? That recommendation is well established. But risk management sections of structured violence risk assessment tools, if included at all, tend to be quite broad, in my opinion, and provide little structuring for users seeking to tailor risk management recommendations and practices to different situations and settings. Others have also previously questioned how far along we are as a field in structuring violence risk management judgments. The second prompt was that, I completed my predoctoral internship in a civil state psychiatric hospital, which was the home of many persons referred due to incompetence to stand trial, or who had been adjudicated as insane and were subsequently stepped down from the nearby forensic psychiatric hospital, who were otherwise civilly committed in part due to concerns about risk for other directed violence. And witnessing and experiencing also, my fair share of verbal and physical aggression while training there and then at state hospitals that I had externed at, et cetera. Another example of witnessing violence risk management needs in outpatient settings, I'm currently supervising doctoral students in a university-based training clinic serving persons undergoing reentry from federal prison. And my trainees have occasionally sought supervision about clients making references to their risk for engaging in future physical violence. And funny enough, I don't teach our law and ethics course in our Ph.D. program in clinical psychology here at MSU. But oftentimes the instructor of that course and colleagues will reach out when our students or our externs have questions about other directed violence risk management. So some other prompts for the project was, so early in my career, still early in my career, but very early in my career, I was moonlighting in private practice and doing some police and public safety work, but also doing a fair amount of outpatient DBT treatment, mostly for youth and young adults with a history of self-harm behavior. And in doing that work, I noticed some examples of greater specification of self-directed violence risk management strategies. And I also had generally been aware over the years of the somewhat parallel, if you will, literatures with respect to behavioral health emergencies, right? So other directed violence, self-directed violence, and maltreatment of vulnerable populations, as well as the threat assessment and management literatures. So to go back to my private practice, early career experiences, right, I regularly needed to appraise and manage risk for self-directed violence. And I discovered useful resources like the Linehan Risk Assessment and Management Protocol, the LRAMP, which I'm going to refer back to several times during this talk. Another prompt was that a book chapter opportunity was referred to me, and I decided to agree to do it because it was a very training-oriented chapter. And given what I've been doing over the last couple of years is DCT and being generally interested in this area and looking to add something new or to bring together things that are already there in a more user-friendly way that I've like to think I've picked up over the years to be able to give it to others more readily. I decided to write that chapter, and it evolved into a focus on behavioral health emergencies broadly, right? So those three categories of other directed violence, self-directed violence, and maltreatment of the vulnerable. But I didn't just want it to be a chapter that was buried in a book that folks may or may not see. I wanted to use the opportunity to write the chapter, but also springboard that into the development of something that was more like a usable chapter, if you will. So really what I was seeking to do here was synthesize developments in other directed violence risk assessment with those for self-directed violence risk assessment and management and behavioral health emergencies more broadly. So just a few more prompts here. So I sense there was benefit of, just like folks have found benefit in structuring violence risk assessment judgments, that there may be benefit in also structuring judgments about violence risk management. And there are plenty of recommendations about violence risk management in the literature, right? So in a sense, what I'm presenting is not new, it's just a new way of bringing together that information in a distilled and organized way, poised for implementation via prompts and reminders in uncertain and stressful circumstances, right? So there are numerous articles, chapters, or tools that focus on other directed violence risk assessment, the duty to warn and protect, threat assessment, safety awareness and de-escalation, evidence-based treatment programs for violence risk, clinical documentation in those situations, etc. But I've just long felt that learning about and synthesizing this all in one's mind requires a great deal of effort, and that many key pearls of wisdom across these areas could be streamlined for trainees and staff. I will highlight, though, a nice series of interrelated articles by Hal Wurtzel and colleagues published in 2020 and 2021 in the Journal of Psychiatric Practice, which I think generally consistent with my efforts, but in journal article form. And then lastly, the guides are new, and it was the intention that they be evidence-informed at this stage, but they are as of yet not evidence-based, and that's an important qualifier to which I'll return to at length later in the presentation. So two unpublished lengthier chapters ultimately informed the single reformulated and briefer chapter that I mentioned earlier, and all three informed development work on the guides. So just presenting those references for you here. And I'll talk more about those chapters a little bit as we go. In short, if one wants access to them, happy to share the drafts. And the guides are currently available at this link. And I actually recommend that you view the posted samples throughout this presentation. So I know you can't click the Zoom screen here, but if you go to Google and you type Chris King Lab, my lab website will come right up. And if you go to, I think, research areas, you'll see violence risk management guides. And there, I've posted PDF copies of both the long form and the short form of the guide. I've currently named them the Violence Risk Assessment and Management Guide, version 1, the VRAM-G, and the short form version, the VRAM-G-SF. So the actual guides that I originally developed are in dynamic Word versions so that folks can, click the check boxes and expand the text boxes as needed, et cetera. But for now, I've just posted the PDF versions so folks can take a look at them. So feel free to type in that URL or just Google chriskinglab.com if you want to scroll through the guides as we go. I think it'll be easier to see them if you have a copy open on your screen relative to all of the guides are screenshotted throughout the subsequent slides, but I just think it'll be easier to see and to kind of refer back to as you go. And so I'll continue to archive the guides there so that folks always have ready access to them if they would like to use them for different purposes. What those purposes might be, we'll talk about soon here. Okay, so I've talked about the general prompts for my development work on these guides. So next I want to talk about the specific key sources of inspiration for them. So while there were many assorted sources of inspiration for the guides, to highlight the chief sources, the first was the logic of checklists for complex tasks in general. So think the best-selling book from a few years back, The Checklist Manifesto. Of course, such a logic is part and parcel to structured approaches to risk assessment, including those commonly employed in inpatient settings, such as the Broset Violence Checklist for acute short-term risk of aggression. So I referred back to sources like that as I went. But even before that more general influence, it was really the Linehan Risk Assessment and Management Protocol, the LRAMP, for self-directed violence risk assessment and management, which was truly the original source of inspiration for these guides. So I've tried to link to all these sources of inspiration, but if you don't have access to the slides and you're just looking at the Zoom screen right now, you can Google these things as well, right? So if you type in Linehan Risk Assessment and Management Protocol, it's freely available from the University of Washington. You can take a look at that. It also is sometimes referred to as the University of Washington Risk Assessment and Management Protocol, the URAMP. So you can find it both ways and take a look at that so you can see some of the sources of inspiration here. And even when it comes to proprietary risk assessment tools that served as some sources of inspiration, oftentimes, the tools that I had pulled from and thinking through how I wanted to structure my guide and some parameters to include, at least while not the manuals, the records, the forms, if you will, usually samples are posted so you can take a look at those as well. Now, another key source of inspiration kind of came after I developed a draft of the long form guide. In further reviewing developments within the self-directed violence risk literature, it occurred to me that a short form version of the guide may be useful as a complement for use in some settings and situations, such as on inpatient units. But once users were trained in the long form version of the guide. So the major source of inspiration for the short form was the brief suicide safety assessment guide from the Ask Suicide Screening Questions Toolkit from the National Institute of Mental Health. Of course, the utility of structured professional judgment, or SPJ, approaches for other directed violence risk assessments been well established, and folks can refer to meta-analyses or narrative reviews by Sina Faisal and colleagues from 2012, Kirk Halburn and colleagues in 2021, Jay Singh and colleagues in 2011, for evidence of this, just to give you some examples there. The extent to which SPJ scholars have sought to advance violence risk case conceptualizations, including to some extent within SPJ tools themselves, I think is also commendable, as evident in tools like the HCR20v3 and the Structured Assessment of Protective Factors for Violence Risk, the SAPROF for short, and further described in chapters like one in 2017 by Stephen Hart and colleagues, as well as one that Steve did with Kevin Douglas in 2023. So I sought to distill the essence of what these tools and authors have thus far recommended in terms of risk management practices. And so moving on from the overall prompts and the key sources of inspiration for the guides, now I'm going to show you the structure of the guides, right? So here on this slide, you can see the general organization in terms of sections of the guides. Prompts for use, violence risk assessment, little asterisk there, because I'm going to speak at length and add a lot of qualifications to that section. And then we'll get to really what I think is the novel synthesis represented by the guides, sections 3 and 4, which are violence risk management and reduction, and then violence risk opinion and disposition, as well as a reevaluation plan. And then finally, just a page for additional summary or attachment of notes and the like. So let's get into it so you can start to actually see the guides. So one way to see this overall structure is just to look at the short form version of the guide, which I'll kind of pause for a moment here so you can scan through it. Of course, right, the overall structure of the guide is indicated by the larger and boldface font. Some various prompts, because it's a short form, doesn't have nearly as much detail as the long form guides in red. And then that kind of goal to facilitate checklist-based decision-making and or retrospective documentation are kind of listed for you here. Right, so just an example of the overall structure, just using the short form version as an example. But now let's unpack these sections in terms of content and themes in the guides and turning to the long form guide. So when it comes to the prompts or the reason for use, some of those prompts were inspired by the LRAMP, but also by my own personal experience and review of the literature, which again, folks can refer to the forthcoming chapter or the lengthier draft chapters that I'm always happy to share with anyone. And I'll provide my email address so folks can always reach out to me if they're interested, if they want to use that in the interim, because I eventually hope to create sort of a bit of a chapter, if you will, to include with the guides to expand upon them. But when it comes to the sorts of prompts you might document, and you'll see this on the next slide, examples include a referral with a known history of violence, clients who report new violent ideation, clients who present with increased agitation, clients whom you learn engaged in violence since your last contact with them, and clients who engage in violence during your contact with them. Say they, aggress towards you during a session or while on the unit, right? So on the left side, you can see the specifics of this prompt for use section. Throughout the guide, note that to facilitate flexibility and use cases not anticipated, other boxes are generally provided. So you can expand things that I didn't actually provide a prompt via a checkbox. And you'll also notice that keywords are generally provided in boldface to facilitate quicker scanning of the guide while reviewing or filling it out. We'll talk about critiques later about, is this realistic, the length of the guide for completion. So I have lots of thoughts about that. But one middle path I've tried to strike is to sort of bold-face thing so that folks can kind of quickly scan through that, especially when they're using it in a retrospective sort of way. But also, right, if there's a situation occurring, they have enough time to sort of refer back to the guide to guide some of their appraisal of the situation and the management strategies they may employ, right, that they can quickly scan through it to kind of jog their memory. Okay, so moving to the second section of the guide, where there's a number of things, as I mentioned, I want to qualify here, right? So this is the risk assessment section. So it's important in appraising this section of the guide to note that I was not seeking to develop another risk assessment tool. Rather, because risk assessment is integral to risk management, I simply aim to create a section that would prompt for a risk assessment or documenting the logic for why one was not conducted, and into which such an assessment could be embedded. Right, so I tried to create a frame to basically use another tool or to, if you're going to proceed via unstructured professional judgment, to sort of embed it within the overall frame of this risk management guide. Indeed, in my discussion with one of the risk assessment tool developers that inspired this work, among other constructive feedback they provided, they explicitly cautioned me from characterizing the guide's risk assessment section as a structured approach in and of itself. And I'll return to this a little bit later on in the presentation. So to this end, users are prompted to specify use of structured or unstructured approaches for other directed violence risk assessment, to attach any structured tools they used, or to document all that was considered if relying on unstructured judgment. Because of course, I think there are many legitimate reasons, exigent circumstances, for instance, right, where completion of structured risk assessment tool may simply not be feasible, a lack of, available information needed to, fill out a lengthy full tool, et cetera, et cetera. So the guides also, so a little bit more about that. The guides include notes and references to highlight some important points if one is proceeding via unstructured clinical judgment, including sources from which risk and protective factors might be drawn, and cautions and recommendations for transparency and humility about the limitations of this approach. So for example, risk factors in the domains of biological, historical, family, social, and environmental, clinical conditions, symptoms, and stressors, attitudes and emotions, capacities, so for example, access to weapons and victims, planning, intent, and non-responsiveness to risk reduction strategies, and protective factors in the domains of internal traits and resilience, attitudes and motivation, and social and other external supports or circumstances. Toward conceptualizing violence outcomes, the guides include notes and references suggesting anticipation of the nature or type of violence, probable victim or victims, and likelihood, severity, and imminence of violence. Relatedly, toward conceptualizing risk and protective factors, the guides include notes and references to the applicability of factors or their hypothesized functional relevance to a violent outcome or risk management or reduction, as well as their related level. Notes and references are also offered for anamnestic assessment, functional or chain analysis, and a conceptualization narrative. One functional theory I also incorporated, and it's from the I3 approach to intimate partner violence, and specifically its sequential process concepts. The first is instigating context. And so this is situations one encounters that initially prompt anger or a violent urge. Second are impelling factors, and these are personal or situational factors that psychologically further one's violent urge. And third are disinhibiting and inhibiting factors. And so these are personal or situational factors that interfere with or aid self-control. I felt that many risk and protective factors for violence could be conceptualized as impelling and disinhibiting or inhibiting factors, whereas instigating context is what clinicians learn about when they say to a client, "Tell me what happened," the who, what, when, and where. I felt these concepts served as a useful heuristic to help bridge functional analysis frameworks. So for example, chain analysis, or functional behavioral analysis, or anamnestic assessment to some extent, with lists of risk and protective factors. I think this can help to promote clinically productive conceptualizations of violence risk And by that, I mean to make thoughtful, functional, and inferential sense of a pattern of risk and protective factors to arrive at final opinions about risk management needs and strategies. So let's look at this section. So here on the right, you can see the prompts for clinical justifications for not conducting a violence risk assessment, of which there are many. Or if a violence risk assessment is conducted, on the left here, for what violence risk outcomes or outcomes were assessed, via what approach or approaches, and what risk and protective factors were considered. Moreover, on the right, you can see the contours of potential future violent incidents of concern in terms of type, target, severity, likelihood, and imminence, which many folks will discuss, right? You'll see it, these sorts of parameters talked about in tools like the HCR or the SAPROF. You'll see them talked about by folks like Jen Scheme and John Monahan, Kirk Halbrand and colleagues, etc. Okay, so moving beyond that, let's get into the more novel syntheses represented, and in my mind, hopefully by the guides. So let's start with the risk management and reduction section. In conceptualizing this section, it's important to note that there's no calculus for the indicated strategies, by which I mean there's no necessary nor sufficient combination for every client. User selection among some of these strategies with a given client will involve professional judgment and trial and error. However, some are especially highly recommended when dealing with behavioral health emergencies, such as supervision and consultation, and some are mandatory, especially documentation. And you can see here on this slide, of course, I'm narrating on top of it, right, given the amount of material to show to you, what some key sources of influence were, where these strategies came from. But of course, this is documented more fully in those chapters I mentioned. Okay, so there are a lot of strategies represented by the guides and many, many more sort of fine-grained presentations of the strategies in those chapters. And so this was one of the reasons for creating the guide, right? To sort of try to drill it down to its essence in a usable form. And so more specific examples of these classes of strategies that I tried to conceptually organize are in those chapters. And so really what I'm trying to do with the guides is to strike a balance between the summary classes you can see here and the lengthy listing of more specific strategies in those chapters. So the guides currently are reflecting more summary 1, okay? And so this tends to be how you hear other directed violence risk management strategies characterized or represented or termed in the literature. And these are general prevention or personal safety awareness, safety planning, including with respect to weapons, treatments, de-escalation, nonverbal, verbal, involving others, or other miscellaneous de-escalation strategies, assertiveness, distancing, and other crisis management strategies, referral to inpatient or emergency care, and warning others. Originally, I had tried to create a summary that was a little bit more, we'll say, oriented towards sort of the spirit that a clinician would try to want to honor or to implement in pursuing other directed violence risk management. And this summary, conceptually, in my mind, was to be proactive, to be discreet, to be cautious, prepared, and aware, to be calm, confident, clear, and assertive, to be concerned, compassionate, and empathic, to be collaborative and creative, to be relieving, and to employ psychological and psychiatric interventions as one potential strategy. So let's go down from summary 1. Here on the next 2 slides, you can see a prompt for justifying why risk management reduction strategies were not implemented, or else prompts for risk management reduction strategies that, again, were organized within the domains of functional assessment. You can read the individual prompts there, or if you've got the guides downloaded in PDF form up, you can scroll through them there. So functional assessment, crisis intervention and de-escalation, increase social support. And you'll see with some of the strategies, as I said, usually an other box is provided, but for certain strategies, say you obtain the client's commitment to no violence until, say, when, right? So maybe it's till the next session, right? Kind of a common strategy employed for self-directed violence, right? That could potentially be extended to other directed violence, right? So the idea here is to document things, right? Whether the strategies all have a robust research literature behind them or not, the idea is to document what you did that's sort of clinically reasonable. And documentation is part of demonstrating your clinical reasonability, right? Same thing when it comes to obtaining the client's commitment or a plan for the removal of means or weapons, or at least reduced ready access, where you'd also want to specify what instrumentalities were specifically addressed, by whom is, who is going to address it? Is it the client? Is it loved ones? Is it law enforcement, et cetera? And how's the reduced access going to be accomplished, right? So I've tried to envision certain prompts that are going to require a higher level of specification with subprompts. And then referrals, and then other miscellaneous treatment strategies that users might specify. So from here, we move to the fourth section of the guide, the opinion and disposition section. So this section was inspired by the LRAMP, my own experience, and some that came before in section 3, the risk management and reduction section. So hopefully violence risk management strategies, short of breach of confidentiality and referral to a higher level of care, are sufficient to mitigate probable severe imminent violence. But this section emphasizes any follow-up that may be needed to discharge any incurred duty to warn and protect if applicable. And of course, if not, the logic for why, as well as supervision and consultation and reevaluation planning. So you can see those possible outcomes on the right side here, right? So starting at the top, right, arriving at the opinion, right, that the client's other directed violence risk is not sufficiently severe nor imminent, nor are they sufficiently likely to engage in violence until the next appropriate point for reevaluation of the situation, because why, right? So sort of document your logic. Now, the idea, right, of embedding a other directed violence risk assessment within this broader context of management, right, is in recognition, right, of the interrelatedness of those two responses to other directed violence risk. And so I don't think this section is like sort of skip section 3 and really is just tied to section 2, right? I think section 3 informs your understanding of section 2, right, as you approach this ultimate opinion and disposition section, right? But if you conclude, right, that there's significant uncertainty, there are prompts to obtain second opinions, right? When you're considering the risk management strategy of referring to a higher level of care, there may, in individual cases, be issues that make it infeasible or contraindicated for some reason. So I've tried to anticipate what some of those reasons might be. And you can see more on the left side here about discharging essentially the duty to protect, which may include breaching confidentiality in various ways and referring to higher levels of care in various ways. So I often get questions from trainees or colleagues about, I think I have a Tarasoff situation, right? But where I find they get really uncertain is the range of things they need to do. It's like they don't understand or they feel uncertain about the range of possibilities. And I think if you know the range of possibilities, right, it adds a little order to the confusion that there are bounds to what they may need to do, right? And so I've tried to specify, for instance, right, the sorts of folks who may need to be notified to help manage violence risk, to discharge one's duty to protect. So of course, in the Tarasoff situation, it might be, the intended victim or the victim's family, right, if they'd be in a good position to notify them. And of course, as we saw in the Tarasoff case, right, law enforcement. But I also tried to envision use of the guides, not just in outpatient kind of terrace-off fact patterns, but also in inpatient units, right? As someone who's trained for several years in inpatient facilities, be they psychiatric hospitals or be they correctional settings. So I also try to contemplate what would be the analog in inpatient settings. So folks like clinical and security staff, client social supports, other appropriate persons not envisioned. And I also try to specify what the typical options are for referring for higher levels of care. In the chapter, I try to provide more information about how to find out what the scope of higher levels of care are in your state or in your local area. But in general, right, my sense was it tends to boil down to wellness checks by law enforcement, or different forms of observation by clinical and security staff, referring for further evaluation. This is essentially what folks think of when they direct a client to the local ER, although sometimes there are other crisis screening locations that jurisdictions may employ or utilize, other sorts of outreach evaluation, and arranging for take the inpatient example, for instance, right, an evaluation by a more senior clinician or another discipline or specialty that may have some unique risk management strategies that they're empowered to employ. So think things like as needed medications, physical restraints, inpatient admission in the first instance, et cetera, and of course, an other box. And because the guides very much try to conceptualize sort of the full range of other directed violence risk prompts, assessment, management, and then sort of final decision making and resolution, the guides specifically prompt in this section, right, for a reevaluation plan with other directed violence risk, trajectory towards violence, et cetera, right, being an ongoing evolving process, right? So trying to orient folks to plan for how they're going to monitor as one risk management strategy, how they're going to monitor and reevaluate risk in a way that makes sense. And again, trying to envision reevaluation plans if someone is actually a treating clinician, or if someone's seeing someone in an outpatient setting, or if someone is inpatient, how they would go about envisioning that for reevaluation on the unit, for reevaluation as part of discharge planning and connecting someone to community-based services, and so on and so forth, including no referral for follow-up evaluation being necessary in this specific case. And then finally, a narrative or other notes and attachments can be provided at the end of the guides. So turning now from what the guides look like, I want to pause for a moment to talk about the ever important issue, right, of cultural considerations. So consistent with recommendations in the research and professional literature, one of the violence risk management strategies in the long form guide is remain attentive to client and clinicians' nonverbal or verbal behavior and cultural factors. So for instance, consider the examples of language barriers, culturally rooted mistrust about the intentions of persons in positions of authority, or social psychological research evidencing stereotypes of, say, Black men as more physically threatening relative to, for example, white men. Many references are possible here, so I'll just refer to a narrative article about cultural adaptations of treatment for Russian-speaking immigrants by Jurek and colleagues from 2013, and a series of social psychological experiments reported by a colleague of mine, John Paul Wilson, and his colleagues in 2017. Note that this prompt, while it's currently organized under the domain of crisis intervention and de-escalation strategies, consistent with broader sources of authority within the human service disciplines, it should be understood as applicable to both guides in their entirety, as noted in the outset of the long form. Refer, for instance, to the APA's 2017 Multicultural Guidelines, an ecological approach to context, identity, and intersectionality. Some additional cultural considerations. I took a look at some research about some workplace violence against healthcare providers, right? And one nice article I found was a narrative review by Kamari et al. From 2020, right? And they give examples in terms of trying to apply the the VRAM-G in a culturally sensitive way, right, is thinking about it in systems context, right? So policies and specialized training and how different gender expressions and identities experience violence, consideration of cultural perspectives on or relevance of different forms of workplace violence and terminology used to communicate it, and policies to manage instances of discrimination to decrease feelings of inequity as an aspect of invalidation. So sort of undergirding all of the violence risk management and reduction strategies, right, is trying to incorporate this spirit of cultural considerations. There's another nice systematic review by Hallett and Dickens in 2017, right, where they list the de-escalation theme, which, to show you how developed this area is, only came from one article in one chapter, right, of cultural awareness. So I do agree, right, more is probably needed here. And so that de-escalation theme of cultural awareness, right, was towards minimizing cross-culturally rooted misunderstandings and a provider and client reading one another. So you can see that they're picking up on that, and at least two references specifically informed the item that you saw in the prior slide. And then as a final example here with some specific data points, Klipses and colleagues in 2023 did a national survey of DCTs as well as internship training directors about which among a wide range of different aspects of assessing and managing other directed and self-directed violence, so two of the big three behavioral health emergencies, they actually provided instruction to their trainees in. And so the DCTs reported, right, only 13% of them endorsed educating their trainees about diversity issues in assessing and managing other directed violence. Numbers looked a little bit better, but right, it's still a minority here in terms of internship training directors, where 45% endorsed training interns in demographic factors and 41% in diversity issues as related to assessing and managing other directed violence. And as a point of context, or a point of reference rather, endorsement rates were higher for self-directed violence. So again, I agree that more can be done in attending to this more meaningfully in other directed violence risk assessment and especially management. So turning now to some potential benefits of the guides. So I'll get into critiques I can see for the guides as they currently stand in just a moment, but I'm happy to share the guides now, in part because Anthony and co needed a presentation this week, and in part because I think the guides may have some usefulness right now. For instance, the guides might be used as a primary or complementary resource in teaching courses about forensic interventions, along with supplemental resources and readings, or in one's own self-study. Similarly, the guides might be used to facilitate prep work or debriefings and didactics in supervision of trainees or staff, or in consultations offered to peers. For instance, about what they might do, what they did do, what they didn't do, and ideas for what they could do moving forward. As an extension of this, the guides might also be used as a documentary aid, either in the sense of you actually using it as a template or else referring to it and completing approved documentation templates used in your setting. Finally, similar to the LRAMP, the guides might be employed in proposals for studies of violence risk interventions as an evidence-informed protocol for violence risk management, even if not evidence-based. So being mindful of time, let's turn to critiques that I can foresee of the guides as they currently stand. So one question might be, why the constructs that you worked into the guides? So I'll just say generally, my thought here is that the guides are meant to be reasonably flexible, inclusive, and generic in their terminology and conceptual ideas. I do think, pitching some structure that I've found helpful in constructing the guides and thinking about things generally in practice. And so, I offer recommendations, but always in the spirit of flexibility. That folks are kind of free to conceptualize cases via their preferred terms, or perhaps they've got models that they're pulling from and they're more informed than me. Great, right? That's great. Incorporate it. There's lots of other boxes. There's sort of a case conceptualization summary that can be provided at the end, and folks are welcome to incorporate additional information. Now, you may say that gets you away from the idea of structured professional judgment, but I'll talk about that on the next slide. Next critique that might be raised at this point is that the long form is simply impractically long to be all that useful. Now, I will say, even being reasonably well versed in what to do, I still found it useful, meaning confidence boosting in stressful situations, to prospectively complete the LRAMP with clients at acutely elevated risk for self-harm whenever possible in determining subsequent risk management actions. If I had time to complete the LRAMP, I did. And so I think this can be likened to some Tarasov type situations. The length of the long form may also be useful in retrospectively documenting unstructured decisions as to emergency actions taken in exigent circumstances in forensic facilities. For instance, right, if you have to manage something immediately on the unit, of course, you're not going to have time to pull the guide and use it. But if you're going to document the incident, right, I think the guide could inform some of that work. Relatedly, it may be useful prospectively in the sense of hypothetical training activities with students and staff, and similarly in debriefings of exigent incidents. So, for example, retrospective root cause analyses. Moreover, the guides still require a good deal of professional knowledge about relevant concepts and strategies, such that it's hoped that they may offer a useful bridge for learning, refreshers, and reminders. And really, that's the heart of it. I try to create a bridge resource here between chapters and journal articles, etc., and actual practice and training. Another critique is that the guides don't reflect the full range of threat assessment scenarios nor management strategies. So admittedly, I'm most familiar with outpatient and inpatient treatment settings versus, for instance, the work of threat assessment teams in schools and workplaces. So I did tailor the guides for the former contexts. Conceivably, however, experts in threat assessment and management could develop similar structured guides for their contexts and functions. And similarly, the guides were designed for the behavioral health emergency of other directed violence and not maltreatment of vulnerable populations, such as child abuse. Significant adaptation by experts in maltreatment of youth, older adults, persons with cognitive deficits would be needed for such a purpose. And of course, there are already good resources for the behavioral health emergency of self-directed violence, so I don't think more is needed of this sort over there. And lastly, I'm a psychologist, so the guides are less specific about risk management strategies that might be employed by medical providers, such as orders for as-needed medication or physical restraints, for which the guides recommend referral to an appropriate professional for assessment and management along those fronts. So then there's the question, is this a structured professional judgment tool? So my current feelings are mixed as to whether to further develop the tool wholly in the SPJ tradition, including not wanting to reinvent the wheel with respect to risk assessment and the complexity of studying the reliability and validity of the management and disposition sections. A risk assessment tool developer noted in their feedback on an earlier draft of the long form that hallmarks of the structured violence risk assessment tool include a detailed manual with clear operationalizations of risk or protective factors, and research evidence for the tool operating as intended, including in terms of reliability and validity evidence. As I've tried to underscore, the guides are currently quite a ways from that ideal stage. And then there's the critique, right, that this presentation is premature, that dissemination should await research. So as a point of comparison, the LRAMP, aka the URAMP, was disseminated widely in an article in 2012. It had first been developed to reduce anxieties of providers, for assessors unaware of condition assignment and clinical research, and to direct for good clinical care and documentation in general. At the time of the article's publication, it was being used in a university-based training clinic and in 5 then ongoing trials of DBT. It had also been recommended for use by NIMH by that time. The extent to which that measure was and has since been validated is questionable. I'd suggest that it's best to think of the current VRAM-Gs as usable book chapters on managing violence risk, as indeed they were developed in connection to my work on book chapters on that topic. And finally, potential future directions for the guides. So here, right, I envision some lines of research that may be pursued with the guides. So the first type are feasibility studies. So think expert panels, focus groups, and the like. They might be employed with a range of stakeholders as a starting point in evaluating perceptions about the content and utility of the guides, or experiences when using them. And as I mentioned 2 slides ago, conceivably, the guides could potentially serve as a basis for significant adaptation work for the behavioral health emergency of risk of maltreatment of vulnerable populations. As for reliability work, given the nature of the guides, inter-rater reliability is the relevant reliability indicator that could be studied in reference to risk management and disposition sections of the guide, at least in an after-the-fact sense. So for instance, 2 or more research personnel could complete the guides based on video recordings of actual or more likely simulated client sessions, or if the guides were filled out after the fact based on prior clinical documentation. The consistency of their ratings of what they observed have occurred, perhaps at the broadest level of items within these 2 sections, could then be assessed. And finally, validity. So in terms of content validity, similar to feasibility research strategies, feedback from stakeholders could be used toward assessing the content validity of the guides from different perspectives. So for example, experts and clients. In addition, the quality of risk management clinical documentation could be compared between cases in which the guides were employed versus those in which they were not. And finally, outcome validity. So from a training or instrumental perspective, one outcome that could be assessed is trainees or staff's self-rated confidence in managing other directed violence risk before and after training in the guides, or in cases in which the guides were used or not. The impact of the guides on ultimate outcomes would doubtlessly be more difficult to evaluate, though pre-post implementation designs or comparisons of cases in which the guides were used or not in reference to proximal incidents of violence could conceivably be brought to bear on such a task. So since we have a little bit less than 10 minutes now, I want to wind down here. So I'll be presenting the guides at the APLS conference next month. But besides sharing with a few colleagues and students, this is the first time I've widely shared the guides. So I'd be thrilled to use this time to answer questions and respond to any initial thoughts and feedback from the audience. And while I do hope to conduct some research on the guides myself, I'd welcome any interested collaborators. So because this is for CE credit, before I turn it over to Anthony to field any questions, so folks can see the bits of evidence that inform this presentation. These are represented in the chapters, among many other references. But so folks can see specifically the different types of primary source references that informed this talk today. And then Anthony and co will share with everyone the evaluation link.
Yes, thank you so much, Chris, for navigating us through all of that and this overall approach. I appreciate how this hits both a proactive mindset before you get into your clinical work, while also in the middle of an assessment, how it can help guide, while also helping inform how you might write and communicate findings to other people that are impacted by our risk management approaches as well. We have a number of questions already. We'll get through some of those. If you have any other questions for Dr. King here, feel free to enter them in the Q&A box. The links for the CE survey should be working for you. And go ahead and check that, copy paste if you need to, if it's not working for you now, or make sure to save it before we leave here. Someone had a question here about just clarification on one of the final things that you had said there, again, of clarifying, like, from your perspective, why you would not consider this a structured professional judgment tool for now.
Yeah, and I think it's fair for folks who have developed those tools to remind that some of the hallmarks of structured professional judgment tools include, right, detailed operationalizations of the factors to be considered and a finite listing of factors, given that lends to, reproducible research on those tools, right? So I agree, right, with cautions that I don't necessarily refer to this as a structured professional judgment tool. What I refer to it as is a structured tool, a structured aid, a structured resource for training and potentially practice, but understanding that as of yet there is no research that these guides are that have been conducted with these guides, right? They are informed by research. They are not evidence-based in and of themselves. So I just like to add that important qualifier that I do think that SPJ tools represent clear operationalizations of their factors and an evidence base, a line of research to support their utility, among other hallmarks of SPJ tools that this simply is not yet.
Certainly, fair enough. Kind of merging two here, somebody that wanted to thank you for the talk and said that they're planning to use it as an adjunct to the HCR 20. With that in mind, somebody else asked, like, in terms of tools for assessing violence risk assessment, what is your preferred structured tool for the risk assessment aspect?
It's an interesting question. I can say what certainly heavily informed these guides, given, I was really thinking outpatient private practice settings, inpatient hospital settings. So when it came to inpatient, the BROSET violence checklist was certainly a source of inspiration, actuarial tool. And then when I was thinking of some structured professional judgment ideas, I really do appreciate the case conceptualization advancements coming from folks behind the HCR and the SAPROF. So those were certainly major sources of inspiration. And then, interestingly, a lot of self-directed violence risk assessment resources and tools. I really I saw that they were a little bit further than us on the management side. In some ways, right, it's debatable, but we might be further than them on the assessment and case conceptualization side. So, I wanted to kind of merge and synthesize the two and create something that may be useful to folks that sort of picked the best of both worlds to try to create something new that, again, was already there. I don't think folks aren't aware of this information. I just tried to bridge it and make it a little bit more digestible for folks and user-friendly.
Absolutely. Thank you for that. Someone said they're curious how you believe your own positionality would contributes to conducting these types of assessments.
Yeah, I was thinking about that right before the presentation, funny enough, and I think I respect assessment. Assessment is an integral part of management and treatment, but I do think my heart's heart, I'm more of a treatment and a management guy, right? I feel like the work is undone when I just render recommendations, and that's the end of my work. So I've, kind of been repositioning myself early in my career, right, to make sure that I'm involved, in treatment and management type services, rather than just pure assessment services. And so I would say that is really what inspired the whole work. So much amazing work has been done in the assessment space, and so much amazing work has been done in the management space. And I just wanted to merge my appreciation for both, given that my spirit is really aligned with the follow-up work of risk assessment, which is management, monitoring, and reduction.
Yeah, I can see that even in the just having the column that considers protective factors here, given just the long time state of risk assessment that's focused on risk from one lens, and just even within an assessment aspect, considering protective factors has that that broader, more holistic implications of the person that we're evaluating. So those factors and that consideration is much appreciated too. Somebody else asked, how much would you consider the disposition checklist needing to be modified to meet criteria for alerting others as dictated by particular state law or facility policy? With those kinds of things in mind, would you suggest people modify this for their institution or their particular situation?
Yeah, certainly. I do try to caution about practice uses because I know there are many things that need to be considered there. So my position was this, right? Like, I greatly appreciated, right, that Lenahan made a lot of tools that she developed for her clinic widely available for folks, right? Not at cost, just go to the website, download the PDF. And I worked from there, right, as a clinician. And so I wanted to honor her spirit and do the same, and make these freely available and sort of leave for folks, right, like discussion and conversation and review with their colleagues, supervisors, staff, administrators, et cetera, about whether this would be a useful aid informally or formally. And it's there, right? And so if folks want to run with it, feel free. If you use it for any sort of commercial purpose or heavily adapted, I think let me know. I haven't really thought those things through too much, right? But I'm always happy to collaborate, and really I want to share. And so if this is helpful to folks and they can think of different directions for it, I'd love to hear about it, and potentially, partner with you to make that happen. So thank you, of course, to UNM, right, for the opportunity to spend an hour sharing this work for the first time with folks somewhat broadly.
Absolutely. We're thrilled to have you here sharing that work. And that lab website link was chriskinglab.com. Is that correct?
people come up with cutesy names for labs. I never could come up with one. So it's chriskinglab.com. Yeah.
Yeah, easy to remember. So thanks a lot for so much for that helpful discussion, the easy accessibility here. And again, if you see Dr. King at the American Psychology Law Society conference next month, as he said, he's looking for collaborators, happy to accept feedback. And thank you so much for initiating all of this and all the work you're doing in this risk management perspective. It is much appreciated on behalf of the field, I'll say.
Well, thanks to everyone for spending their lunch with us. And thank you, Anthony, and everyone on your team for providing this wonderful resource to the field.
Absolutely. Thank you for that. That wraps up this week's Law and Mental Health series. We hope to see you next week with Pamela Yates discussing self-regulation models for understanding and treating sexual offending behavior. Until then, have a fantastic rest of the week. We hope to see you again.